wanted to say thanks for coming, everybody. It's a funny, we're doing a hybrid event again today. We're really trying that out. It's not the easiest thing, but it's really lovely to have. We have a few people in person and a number of people online, so that's fantastic. And so I wanted to, welcome everyone. Thank you so much for joining us. It's going to be an amazing topic. And we're really looking forward to this. And I've been planning this with you for quite a while. So this is really exciting. My name is Simona, and I work for the Center for International Child Health, as well as I do some work for SPPH as well. These lunch and learns are monthly. They used to be always in person, then they were hybrid during COVID, and now then they were on virtual during COVID, and now as I just mentioned, we're trying the hybrid version. So we have monthly lunch and learns with expert global health speakers. There's an annual global health conference coming up that CICH, Center for International Child Health, and SPPH are co-hosting, and that'll be in March. And we also have different like practicum events for those that are looking for an MPH practicum in global health, and we try and match you with a PI. So if anyone has any questions about that, don't hesitate to contact me. We're going to have about 30 or 40 minutes, or 30 minutes, 40 minutes of presentation. And then we will have a question period. And Stephanie, a colleague from the Center for International Child Health, is on the Zoom call and able to monitor. We can decide if you want her to read out the questions. She can do that from the comments, or people can ask directly. So up to you how you want it. We can get to that when we get to the question period. We want people to ask questions throughout the process, or maybe at the end?
Well, I would love it to be interactive. Okay. So if folks do have questions during the presentation, feel free to bring them up.
Perfect.
Unfortunately, I don't know if I'll be able to monitor it.
Yes. So Stephanie can monitor the chat.
Okay, phenomenal. Yeah. So please bring up questions as we're talking, and then we'll definitely have a lot of time at the end to discuss this topic, but then hopefully other issues about global health as well.
Thank you. And so we're delighted to have Dr. Veena Sriram joining us today. She's an assistant professor at the School of Public Policy and Global Affairs with a joint appointment with SPPH. Her research sits at the intersection of global health, social sciences, and public policy. And her interests are understanding power and politics and health policy processes in low and middle income countries. She's done extensive research in the national and the state level in India, and her work has been published in many journals, interdisciplinary journals, and she also continues to write on contemporary issues in global health, which is excellent, and always sending me really important and interesting articles to share with everyone. So I'm trying to put those out on the listserv, the Global Health listserv as well. For those that are in person, there's a little bit of a small grab-and-go lunch. If you want, in case you're missing, you have to run to class and you're missing your lunchtime. And so I will hand it over to Veena and say thank you so much for joining us, and really looking forward to it. And so people feel free to ask questions as we go. This is meant to be a little bit less formal and more discussion based. Good, Stephanie?
All good, yeah.
Okay, perfect.
Excellent. Thank you, Simona. Thanks to everyone who's here, and thank you to those online for joining. As Simona mentioned, my name is Veena Sriram. I'm an assistant professor in global health policy here at SPPH and SPPGA, the policy school. And today I'm going to be talking about power and politics in global health, taking the very specific angle of medical specialties and what we can learn about power and politics by examining the development of medical specialties. In this case in India, but I would say in low and middle income countries more broadly. Let's see, am I doing this right? This slides, move the slides down. Yes, there we go. Are the slides moving for those online? Yes, they are. So I'm going to spend about 30 to 35 minutes, and again, would really encourage questions as the talk is going on. So I might end up speaking longer than that, but hope we can keep it as interactive as possible. I'll start out with a quick introduction to myself and my research. This is really also a chance for me to get to know all of you. I'm very new to this school. I only joined in January, so I'm very keen to learn more about all of your interests in global health and where there might be intersections. So definitely feel free to talk those up as we discuss these issues for the next hour. I'll then spend some time on why we have to understand power and politics in global health, why it's important, and then spend most of the time on this case of medical specialization in India as a way to sort of empiricize this topic. I'll end on some future research ideas, and that's another place. That's another place that I'd really love to get feedback and suggestions and ideas from all of you, because this is a work in progress, sort of this plan of to expand this research focus. So it's a good time to get suggestions for new directions, and then have a lot of discussion with all of you. All right, so it's gonna take me a second to get used to this slide. Okay, there we go. So my research interests are really at the intersection of a couple of different ideas. And I think that the joint appointment between the public health school and the policy school really reflect where my research sits, which is around health policy, but taking a more critical lens at understanding the politics of those processes. Why do certain policies gain attention? What interests influence their formulation? What does that mean for implementation? What does any of this ultimately mean for equity? Those are the questions that I'm really trying to understand. Delving a little, hello.
Sorry, this is my class ran a bit late. Sorry, these are all the trainees. Sorry about that.
It'll take the pressure off of this side of the room. I've been staring at them. I can kind of expand my focus a bit.
Thanks, you guys, for coming.
Yeah, hi everyone. Okay.
There may be a few more trickling in.
No worries, no worries. Maybe I'll do a very tiny recap just to say that I'm a new faculty member here at UBC. I have a joint appointment with the policy school and the public health school, and that really reflects where my research sits, which is around the politics of health policy processes. Why do certain policies gain the attention of policymakers over others? What does that mean for formulation, implementation, and ultimately equity? I've tended to take a more narrow focus on two areas in particular, governance and health workforce issues. And most of my research sort of sits at this intersection of governance, politics, and health workforce. In terms of how I do this research, I use a lot of social science theory and methodology to understand power and politics. I work almost entirely with qualitative methods, but really increasingly more interested in working in a mixed methods way. And I can talk a little bit about that in the discussion as well. So for this talk, I'll be focusing on specialization as sort of a reflection of this, but I'm again very happy in the Q&A to share other research projects that I'm doing, for example, on governance at the state level in India during COVID, and why certain states approached COVID more effectively than others in India. And also some work on global health protests that actually Karthik will be joining us in our group to examine. Okay. Why do we care about power and politics in global health? I think at every level in global health, from micro to meso to macro, power is really at the heart of a lot of the inequities that we see and experience, and in this school that we want to address. And even starting from the patient level, we see, for example, a lot of cases of disrespect and abuse in maternal health. But these are just kind of snapshots or examples of how power manifests in different ways. In terms of this meso level or country level, we see so many examples of power and politics influencing access to services, the delivery of services, how health and how social forces really impact how services are delivered. So here's an example of community health workers in India going on strike after not being paid for over a year. This is an example that hits closer to home. This is from Vancouver, where health workers were the brunt of protests from the wider community. And then finally, we see this at a very macro level as well. This was exemplified during COVID. Two examples here of the US and Brazil in terms of how those governments addressed the pandemic and the real, I'd say, devastating loss of life that's occurred as a result of it. So all this to say that global health is very much beyond just looking at programs and interventions, those are clearly important and necessary, but we do have to kind of put them in this context of power and politics to really get to the heart of inequities that we're experiencing. So medical specialization, the focus of the talk today, in my view, exemplifies a lot of these issues, and I'll hope to make that argument more clear as we go along. Where does medical specialization fit in health systems? So I'm going to take this from two angles. The picture on the left is what's commonly called the building blocks of health systems that many of you may have come across, or many of you may be quite familiar with. And medical specialization really hits at three of these: governance, human resources, and service delivery. The picture on the right is a really interesting conceptual model of human resources for health. And it looks at it from four different dimensions. The cadres can go from specialized to a lay health worker, like a community health worker. They can go from working in the private sector to working in the public sector. And again, these are spectrums, so you can kind of fit within the middle as well. You can be formally recognized as a health worker. You can be doing this job unrecognized without any training. And again, somewhere in the middle. And then you can be doing it as part of a biomedical or allopathic system of medicine, or it can be more traditional forms of medicine. So what I'm really focused on is not just the specialization piece of it, but how that intersects with all these other dimensions. I think that's really important for how we see the system as a whole. So we often think about medical specialization in the context of high-income countries, but I would argue that it's increasingly important to see it as a priority in low and middle-income countries, mainly because low and middle-income countries are pursuing medical specialization policy in a variety of ways. These are just some quick examples. In Lebanon, there are more cardiac surgery units per million than in Germany. In Madhya Pradesh, India, over 90% of medical students want to specialize in some form or the other. In Thailand, there's been a manifold increase in the number of specialists. Now, 70% of health doctors in Thailand are specialists. So this is clearly not a phenomenon limited to high-income countries. This is worldwide. It's just that as a research community, we've not necessarily focused in that direction. I also think this issue of specialization has gained more importance in the last couple of years. One clear example is during COVID, the lack of infectious disease specialists in India was really striking. There are only a couple of dozen infectious disease specialists in a country of 1 billion people. And we'll talk about how that came to be, the regulatory systems and what the problems are. Another very recent example, there was an explosion in Sierra Leone where I think over 100 people died. And because there are no specialized burn units, more and more people are dying as a result because they're not able to get the care that they need. This issue is gaining some, I think, real urgency in the COVID context and, of course, outside of COVID. So where does power and politics fit into all of this? I think medical specialization is often seen as something apolitical. It's something seen as uncomplicated. If a specialty comes to a country, that's sort of seen as irrevocably a good thing. But I think it's important to put that in a wider context and to problematize that a bit. So specialization is increasing in a lot of countries, largely also due to the fact that biomedicine is globalizing. And that's being really pushed forward by changes in technology, mobility, the ways that we communicate with each other. So there's more rapid diffusion of knowledge from a high-income country setting to a low and middle-income country setting. There's also the involvement of high-income country actors in promoting specialties in low and middle-income countries. So academic medical units like the one we're in are actually going to other countries to promote these specialties. And in many cases, diaspora from those countries are really kind of at the forefront of it because they see the need for their countries of origin, and they really want to kind of bridge these two worlds. There's also an underbelly to all of this, which I think is really important to acknowledge, which is the dominance of Western systems of knowledge, right? Due to colonialism, particularly in countries like India, I can speak for very confidently because I grew up there. But I think this is true in a lot of other low middle income countries as well, that Western knowledge is seen as superior. And so if it's being done in the West, it has to be right. So that is sort of this idea of specialty when it's diffused to a setting, it gains traction because of some of these power dynamics as well. And then I think it's important to think about the impact that specialization has on service delivery as a whole. Are we prioritizing more curative, specialized services over public health approaches or primary care approaches? And should these not be integrated rather than being seen as sort of independent of one another? We'll tackle some of these questions in the talk. Now let's narrow in on India specifically. India is a prime example of this idea of medical specialization being the product of knowledge being diffused from high-income countries to that context. And it's gaining a lot of momentum lately for two reasons. The public sector, there's a lot of push now because of universal health coverage to offer a wider range of services. There's also a lot of political support for tertiary care. It is a huge vote-getting policy. People run campaigns with tertiary hospitals as being part of the platform, so it's very popular. In the private sector, about 70% of healthcare in India is delivered in the private sector. And there's a for-profit layer of hospitals that increasingly operate as companies, and they want to differentiate themselves from their competitors. So specialization is seen as part of that differentiation. It's the dominant career goal for most medical students. India has a unique scenario where for every 2 medical students, there's only 1 residency. So everyone is fighting. That 2-to-1 ratio, they have struggled for years to narrow that. And so everyone is fighting to get into a residency because they see that as the ticket to many other things. Another interesting thing about specialization in India, there are very few broad specialties. So in the last couple of years, there have only been 5, including emergency medicine, infectious disease, palliative medicine. Family medicine was only in the 80s, I think, but still only has 1 residency program for the whole country. But there are many super specializations, cardiology, endocrinology, critical care. I'm going to pause here for a second. Any questions on this context?
I have one comment about your previous slide.
Yes.
So I was surprised you didn't have the role of consumers. Because what I find, I do primary care once a week.
Yeah.
The biggest driver for specialization is actually people knowledge.
Yeah.
So it is very, and one of the best things, for instance, that I would say in the pandemic, is by centralizing the medical exemption of vaccination to the public health, to the office of the provincial health officer. That meant us as primary care did not have to be debating with folks as to whether or not they were eligible for medical exemption. Last night, 4 folks, 3 of them concerned about infertility, all of them wanted a referral for infertility. Even though sort of that primary assessment home.
Yeah.
So I think especially in this world, I actually think that's one of the biggest drivers. Folks want to see specialists. They're not in emerge where they don't want the emerge physician to do the suturing, they want plastics. And it's very, very much a very real factor in what's driving sort of the drive to specialization.
Oh, I totally agree, Gina. I think that's exactly right. That consumers, that sort of gets to this point around market differentiation, that consumers are really pushing for this. They really want new forms of specialty. Part of the problem in countries like India is that the inequities are so enormous that the people who can access some of these high-level tertiary specialists in private hospitals in particular are very few. It's a tiny sliver of the population. Most people are in a situation now, unfortunately, where they are happy enough to see a doctor. And the system is unfortunately not set up in a way to assure them quality when they see that doctor. So I think that's a really good point that speaks to the inequities that we have in this, that what's driving it, but then also the access challenge at the heart of this.
And in Canada, we control specialization at the level of the medical school.
One comment, Zoom is asking to speak up when you have a question.
Thank you.
I don't think I've ever been told to speak up in my entire life.
Sorry.
It's super exciting for me. Alicia's laughing at her. In Canada, we, I don't want to say control, but we manage medical specialization at the level of the medical school. So unlike India, where there's a huge number of medical schools, if any, it's very hard to start a medical school.
Yeah.
And we have a lot of government leadership in terms of the number of seats in a medical school. And that all has to be approved from a health human resource planning. So we actually have enough residency spots for trainees, but also in Canada, you can't, you have to do residency. There is no, you specialize in everything, including family medicine, which is a specialty.
I think what would be so interesting in comparing India to Canada is they both have really started off with the same sort of colonial origin, right? Which is I'm assuming in Canada, a lot of it also came from the British system.
Yep.
And it's so interesting that we in India went one completely different direction and Canada went in a different direction, arguably better, as you'll see when I'm going to talk about where specialties come from, which is the Medical Council of India, whose forebearer was the General Medical Council in the UK. And the only reason the Medical Council of India was started was because the British needed a way to verify that medical training in India was up to their level of approval. The problem is that so this is the apex regulatory body for medicine in India. It exists by an act of parliament and it's run by doctors, but it became highly corrupt in the last couple of decades. Their longtime president has, I think, maybe half a dozen corruption charges against him. He's out of jail now and he's back on the scene. He was actually elected the president of the World Medical Association, which shows you the problem with this whole system. But in any case, this is the regulator that everyone has to deal with. And they were hugely flawed. Because like Canada, they took a long time, but unlike Canada, I'd like to know more about this too, Gina. There was zero it was very up to the individuals on the committee, whether they liked the idea of the specialty or they didn't. The inputs into the decision making were not rational, as we'll talk about. Yeah, for sure.
Speak loudly, sorry, when you
just to clarify one thing, as Gina said, here in Canada, when you finish medical school, you cannot practice without residence, but in India you can.
You can, yes. Okay. So India, you go straight to medical school after high school.
And after you finish,
you do an MBBS for 6 to 7 years. And then after that, then you can practice as long as you're licensed by your state medical council. But then you then have to get further training to get an MD or an MS. In further specialization. But I'll talk later. India is one of the only countries that has two systems of postgraduate education. We have one for medical colleges and we have one for hospitals. And I'll talk about that in a second, about why that confuses everything. Things finally came to a head a couple of years ago, and after many attempts at reforming, they finally replaced MCI with a new body called the National Medical Commission. Seemingly less, the word is now that they're certainly not dealing in the kind of corruption that MCI was, but time will tell us about how effective they are as a body. So what are the main challenges when you develop a new medical specialty in India? Well, one is the main thing that we just talked about. There are major health disparities, and who can access private specialty care is a very small slice of the population. There's a very complex architecture for specialization policy. MCI is for medical colleges. And as I was just mentioning, we have a parallel postgraduate system for hospitals called the National Board of Examinations, which was sort of started as a retaliatory move when Britain stopped recognizing Indian degrees in the 70s. And so India said, we'll start our own Royal College equivalent and called it the National Board of Examinations. And till this day, we have this bizarre parallel system. We also have what are called institutes of national importance that are run by the central government, like the All India Institute of Medical Sciences, very highly regarded. Lack of transparency, we don't know what the decision-making processes are. They take years, if not decades, to approve certain specialties. Very uneven uptake of specialties. So when I did this research, there were 26 emergency medicine courses. There was one in family medicine and there was one in palliative medicine. And it's all driven by the market, and we'll talk about that in a second. And very limited integration of specialties across these levels, across primary care, secondary care, tertiary care, and between private and public sectors. So as an example, if I walked into a private emergency room in many parts of the country, I have to pay a fee to be admitted. It will not be, and that's a fee that most people cannot afford. So there are all kinds of problems with this system. So the rationale for this study was specialization is accelerating in India, but we don't have analysis of how specialization policy develops. And how does this reflect a country's priorities? What does it mean about a country's priorities if X specialty gets approved, and not Y or Z? What is that telling us about where the interests lie in this setting? What does it mean that emergency medicine gets approved, but palliative medicine doesn't? These are questions that I think are really important for us to kind of grapple with. It's a window into understanding how the MCI worked, a very opaque body, poorly understood, a way for us to understand how diaspora influence health policy and how academic medical institutions influence health policy. And I think it has lessons for development more broadly. So when I decided, this was my PhD dissertation work. So it was a bigger study. And I ended up looking at this question from three different time points. Agenda setting, how did the policy gain attention? Formulation and implementation I looked at together. What was the regulatory architecture? And then how did power kind of permeate through all of these levels? And I tried to do sort of a comparison with infectious disease, family medicine, palliative medicine. Not a very robust comparison, but I did some interviews with all these stakeholders just to get a sense of how it was for them. I'm going to talk today about only the agenda setting question. But all my papers on this have been published, so definitely would be happy to send them to you or talk with you about them some more. But I'll focus today on the agenda setting piece. Okay, just in the interest of time, I'm just going to really run through the methods very fast, except to say this was a case study where I relied entirely upon qualitative methods, did about close to 90 interviews, observed 6 meetings, and read about 250 documents. Data collection took about a year, and I was based primarily in Delhi and Chennai. Chennai is my hometown, so that kind of worked out in a good way because my child was really small when I did this work, so it was good to have a home base. But I also spent a lot of time in Delhi. So the way that this was done was primarily in person. And I spoke with people from who covered different aspects of this case. So I talked to emergency physicians, of course, Indian emergency physicians from abroad. But I also made sure I talked to regulators, government officials, medical college leadership, and representatives of other specialties. And then ended up trying to talk to these folks multiple times in order to kind of build some trust and rapport. So it had some sort of ethnographic elements to it. Okay, and I won't spend time on the analysis approach, but this is kind of how I put all of it together. Suffice to say, it took a long time, but we got there. I used a framework from Schiffman and Smith on issue ascendance in global health, which some of you may have come across in your work in global health. And Schiffman and Smith posit that there are really 3 dimensions to understanding why an issue gains attention. The power of the actors, how cohesive are they, how coordinated are they, who's in this group, the ideas that they're bringing to the table, how do they understand it as a group, how do they communicate it outside of their group, the features of the problem itself. Is this a problem that kind of like grips hold of people, or is it something that's not able to kind of get people's attention? And then the political context, the policy or the governance structures and policy windows for actually pushing policy through. Any questions before I move into the results? Good part. No? Okay. Okay, so just some baseline context about emergency care in India. It's unfortunately very fragmented and very weak. So depending on your income level in the country, if you are privileged and you have a person of means, you can get some of the best quality in the region. But most of the population is not. And so for them, the system is really all over the place and not of good quality. And of course, there's a whole community of people trying to change that. This is not for lack of trying. People have dedicated their entire careers to fixing this problem. It's just an enormous issue that people are chipping away at, but it's just going to take some time. There's a human resource question here in terms of skill levels, which is why emergency medicine really becomes a key part of all of this, and a lack of political prioritization. So as one of my respondents said, the area of emergency room, or casualty, as it's called in India, that's the area of chaos, maximum chaos. This picture in the middle is one that I took at an emergency department. So this is a very typical one. So this kind of gives you a sense of resources that folks have. Typical one in a more rural setting. So emergency medicine really picked up traction over the years as a solution to these problems. And this kind of gives you a timeline of how that happened. I know these slides are probably not easy to read for us in the room, hopefully they're easier for those on Zoom. So emergency medicine emerged as a specialty in high-income countries in the 1960s. And fast forward about 30 years later, you started to see the first emergency departments emerge in India. In 1999, we had the formation of the first medical society, who started to push for formal recognition of emergency medicine as a specialty. By 2005, that community had splintered. There are multiple professional groups for emergency medicine. And also, because the regulators weren't approving it, people started to offer their own training programs without formal recognition. So imagine in a setting like Canada, if somebody just decided, hey, I'm going to start my own training program without any government sanction. I don't know if that would happen.
It's all accredited. You can't, there's no, there's like, some of you that are probably following SFUs, the government ministry here has set, one of their election promises was to start a new medical school. That will be a 10-year process. And it doesn't even matter if the government wants to start it. They have to be accredited by the accreditation body, which is the ACMC. And they have not accredited it. So it's a very good process. There's no way anyone can just do this. Like, it just doesn't happen.
Well, what's interesting here is that these training programs are actually pushed forward by American universities.
Yeah, sure, because they make money.
Well, that's what's so interesting is there's a whole dynamic here about how global health is dealt with in academic medical programs in terms of the training opportunities for those residents. And that's a whole question we should probably talk about, because I think there's a lot of sort of politics there that is interesting and important to deal with. Finally, in 2009, 10 years later, they got recognition, but showing just the inefficiencies in this regulatory system. 6 years later, 70% of residency spots were de-recognized by the Medical Council of India. So all that work to get it recognized, and then the regulator is like, no, you don't fit the bill for reasons that we'll talk about that were as minor as one of their faculty was on maternity leave, and so she wasn't present for the inspection when the inspectors came. We'll talk about all that in a second. Some of the contextual factors that are driving the growth of emergency medicine are as follows. There's the corporatization of healthcare, as we talked about already. There were a series of natural and man-made disasters in the 2000s. Many of you would have heard of the Indian Ocean tsunami. There was an earthquake in Gujarat. Ambulance systems in the 2000s also started to pick up. And so there's this need to actually have a place to deposit these patients once the ambulance picked them up. So emergency medicine started to gain traction then. And honestly, active recruitment of doctors from India to high-income countries. So I took this picture at an emergency medicine conference in India. This is a recruiter for the NHS who come to India to recruit doctors at this conference. So these are all the kind of social forces that are really giving emergency medicine a lot of traction at this time. This is a picture from Delhi. This kind of just gets to Gina's point about patients really wanting these services. This is at Apollo Hospital in Delhi. And it kind of speaks to how hospitals use specialties as part of their branding. And it's true, like if I had a problem, this is where I would go because I know that the quality is going to be good, but I can afford it. And it's a systems question of how we can make this more accessible.
But it's also interesting, like primary angioplasty, like don't do that because you know, so many people don't need an angioplasty when they're having chest pain. And what we always forget is there's a risk to interventions.
Mm-hmm.
So that sort of stuff is terrible because you're going to be giving angioplasty to people who, you know, maybe have just, you know, some GERD or some reflux, and all of a sudden you're putting them under like a very, very serious procedure that in and of itself has very serious risks, right? And so that's the problem with that. Like, that's just bad.
Yeah, no, this is a great general direction of conversation that I'd love to talk further about, because things like, for example, cesarean sections, the rate in my hometown is 70% now. So there's a real problem around over medicalization. I don't know if you'd call it that, Gina, or interventionists. Yeah.
You're aiming for usually less than 20%.
So it's very, very high now. And it's interesting, there's a Twitter debate about this morning actually, where the OBGYN Society in India was saying, y'all are blaming us, but then you don't have necessarily the system at hand to give us blood when we need it, to give us electricity when our hospitals need it to deliver. So we have to kind of go that extra. And I don't think it's ever as simple as that. I always think multiple things can be true at the same time. So these are very complex issues. I'm going so over time, so I'm just going to spend 5 more minutes and I'll stop. So professional societies were really important to developing emergency medicine in India. But the key thing here is that they were not just limited to Indians. The diaspora started their own professional associations for emergency medicine. You can see one over here, which has both the Indian and American flags, actually 2. Actually, many of them, if you look a little closely, they'll have America in them. But the problem was that there was no single leader. There were many fathers or mothers, is what respondents used to tell me. There are many fathers or mothers for emergency medicine, but there's no real sort of cohesive leadership structure to bring all this together. And there were real power dynamics involved in who was doing the advocacy. So as one of my respondents said, these non-resident Indians, they used to come and tell us, this is happening in the country in which I work, why can it not happen in my own home country? And they brought a lot of Americans and British. So here they're referring to non-Indian Americans and British folks. And then that also kind of speaks to this colonial legacy we have of knowledge expertise. So this quote at the end, if an expert comes from outside the country and tells you something, it makes a difference rather than hearing it from your own people. This problem in fragmentation was one of the fatal blows to the development of this field in India, because there was a lot of tension in many directions about, do you focus on emergency medicine development in the private sector? Do you focus on it in the public sector? Do you focus only on tertiary care? Do you do a systems approach? They could never get the blueprint together. And a lot of problems started to creep up between diaspora stakeholders, Indians, and then non-Indians. And people use this very problematic, but I think interesting analogy of parent and children. And how the respondents from abroad used to say this is that, oh, this is like a child growing up and resisting you. And that kind of speaks to the power dynamic in all of this. The association split. So there are two main associations for emergency medicine now. One works with the private sector, one works with the public sector. And they have different international partners. One works with the Emergency Medicine Federation internationally of physicians, and one works with WHO and CDC. So you can kind of see that medicine, public health split happening in the societies themselves. So this parent and child analogy, there's a quote here. I retrospectively see that it's natural. Why would you go as an international organization into another country and start calling the shots? When your child has grown, they want to move out of the house. International support came and did a lot of good. They organized them, they got them to a level, and they were not liked because their show was being stolen. Really, I think, reflective of what was going on in India at the time. And also this quote about the Americanization of emergency medicine in India. The power of ideas. So I think it's really important to kind of emphasize that everyone really agreed that we need specialists if we're going to have this specialty. The problem was about whether you have a residency program in the regulatory system or you have it outside of it. Do you wait for the regulation to come before doing it, or do you decide that the need is so great in this moment that we're going to go outside of the regulatory system? And some people decided the latter, that it's just too important that we do this. We're going to go outside of the system and do it. And then there are also questions of, are we just kind of copying curricula from America and Britain and Australia? Are we not making this sufficiently Indianized? These two quotes, I think, are some of my most favorite from this study. They, being American doctors, used to come in every year, be there for the conference, go back to talk about what they do in the US, and then go back. I'm not in favor of that, because what happens is you're trying to transplant a system, impose it in an alien environment, and it doesn't take root, and it dies quickly. This next quote, I think, is also very, very telling. There's India and there's Bharat, which is a term you use in a lot of Indian languages to talk about India. The fallacy of emergency medicine is that no one is looking at Bharat. Finally, on the political context, this is a picture of what the regulatory system looks like. And it just shows that for someone who wants to come and do good, this is a context that really disincentivizes that, because you don't know how to do good. You have the Medical Council of India, the National Board of Examinations, the Institutes of National Importance, and these unregulated courses. And professional associations were working with all four. So how do you actually bring this together in such a way that you have cohesive specialty development? This is the guy I was talking about, Ketan Desai, the head. And so this is a very complicated organization, and did not do justice to medical specialization decisions. So as this respondent said, it's not a very thought through established procedure. It's ad hoc as and when, which is an offshoot that the overall regulation of medical education is weak. But things did happen in the end. It was finally approved in 2009. There were still many challenges. They didn't have a curriculum for a long time. Everyone could kind of offer their own curriculum. There's a problem in something like emergency medicine. But the good thing is that because of this, people were trying to do something. They were taking a difficult situation and really implementing emergency medicine programs across the country. So let's just end on some conclusions, and then we'll have a discussion for the couple of minutes we have left. Ideas clearly outweigh actor power here, but the lack of policy community cohesion led to an uncoordinated long-term policy agenda. There was weak national governments, which compounded this fragmentation in the policy community, all these specialty associations. Medical specialization was seen as this social remittance in a way from high-income countries to low-middle-income countries, but there's a lot of tension between these actors. And there was this focus on postgraduate medical education, on specialty care rather than emergency care overall. So I always end with this slide. This is from one of the premier medical colleges in India, CMC Vellore. And it just kind of shows that if you need care, you can find it. It's there. It's just that it's in different directions and it's not accessible to everyone. And this system makes specialty development, particularly for the poor, very difficult because it is really privileging certain viewpoints over others or certain needs over others. I was going to talk about what happened. It's really hard to talk about emergency medicine in India without acknowledging what just happened this year with the second wave. I think it really underscored the fact that our systems are weak and they need to be strengthened. This is one of the largest humanitarian catastrophes that has happened since partition, since independence. And it's important to kind of always remember that this happened. We have a paper on overall recommendations for universal health coverage and medical specialization that I won't go into here. But I'll end on this. So I took a breather from this work for a couple of years. And I'm ready to kind of move back into it now. And I'm designing a study along with colleagues that will take this idea of understanding specialization policy, emergency medicine policy, and broaden that to emergency care policy for jurisdictions. And I had some conversations with the African Federation of Emergency Medicine, and they're interested in doing some comparisons within the region. Some early examples were Nigeria, Tanzania. I had a conversation recently about Rwanda. Very different political systems, very different governance approaches, and very different outcomes when it's come to emergency medicine and emergency care. So I'm developing that study. If any of you have ideas or interest in the space, I would love to hear it. And let me stop there. And thank you. 5 minutes. I'm so sorry.
That was amazing. That was awesome and so much content to go to there. That was fantastic. I'm gonna for those on Zoom, I think you can put comments into the comment section and Stephanie will read them out. And are there any are there any questions in the room?
I have a question about
you have to speak loudly.
In North America, and I'm assuming Western Europe as well, there's a lot of these global health residency programs within our healthcare or within our medical school system that then residents go to places like India and work there for a while. And the targets for the medical schools are often how many people can be placed in these positions? And I guess I'm wondering what role those kind of situations play in all of this.
Yeah, I can give you the viewpoints for some of my respondents on emergency medicine. I would love to hear Gina's take on this from kind of a broader lens, but thinking about emergency medicine in India specifically, there are two camps. There's one camp that thinks some care is better than no care. And so these programs that are started, including these unregulated residency programs, which rely on a lot of this labor from residents in high-income countries coming to do the teaching, or at least be part of the teaching, there's a sense that that's giving care to someone that wasn't there already. So this is a good thing. There's another camp that says absolutely not, because would we allow residents from India to come to Canada and treat patients in an emergency room without any formal licensing to do so here? I don't think so. I don't think we would allow that to happen. I don't think it's legal here. So that is the tension that the critics have with this, to say that our brown bodies, our black bodies, are they different in some way that allows this to happen? And I don't think there's an easy answer to this. I really don't, because it's a very complicated space. But it is important that we're critical about foreign placements and why we do them and who we do them for.
Yeah, no, I totally agree. And I mean, it's outside of medical schools as well. Like I have a friend that was in a midwifery program and went to India, and she was working in these situations, and she was like, "This is crazy. Like, why am I doing this? I don't know what I'm doing," and it's like putting patients in danger because you're having people that aren't trained properly doing procedures that.
Well, it speaks to. I mean, I keep a clear focus in a lot of my research on the impact of colonialism. To me, that's one of the biggest byproducts, is that I even saw this when I was growing up. My parents are doctors. I kind of lived in this world. And anytime a doctor from outside of India came, you could see the respect level just go out like off the charts. And that is true of anyone who's coming in. If you come from abroad, you automatically know more. In the eye, that's how you're perceived. So I can totally imagine your colleagues just like confusion about why she's being given this responsibility. But sometimes people you're being perceived as having some innate knowledge that people, you being your colleague.
Yeah, I think just to give the Canadian perspective, so I can't speak about the US. So there's no any specialty in Canada is like pediatrics or whatever. As part of that training, people may do global health electives. So there's the Royal College and the College of Family Physicians, and they approve all that. The Royal College does actually not let, some of the Royal College specialties, you can't even go over if you don't have a supervisor who's Canadian go. So to avoid, like what you described with the midwifery, that couldn't happen in medicine because you actually have a Canadian supervisor with you. But I think it's the same thing for whether nurses should go, whether PhD here should go and do global health. Like it's the same issue of, are you taking resources? And so it's a really important conversation, and how do we elevate the conversation for the long view of, because my perspective on it is with the right controls, like what you described should never happen, but with the right controls and experience, create, speak about physicians, you can create physicians who have a commitment to global health, so that who can speak knowledgeably about global health. They should not be going over to get experience. That is a remote, and actually the Royal College does a lot. Uganda, and the other interesting thing is, like, for me to practice in Uganda, for all the years I've worked in Uganda, I've never practiced because I actually have to have a medical license. I'm doing some work in Jamaica. I have to get a medical license in those countries. And actually trainees that come, one of the reasons why trainees like to come to Canada instead of the US is residents who come from Rwanda or wherever, they actually can get a license, an education license, and they actually do care. So, we've had Rwandan pediatric residents who, and that, Simona can talk about that. So actually trainees do provide care here. They have to be licensed the same way when I go to Uganda. So I think in some ways actually medicine is more probably governed than perhaps some of the other health professionals. So I can't practice in Uganda if I don't have a license, and my license involves all the same credentialing that I have to do here in terms of medical school and what electives and selectives, and I pass all my exams, and I maintain my competency, and I have to show all of that stuff.
So I should have prefaced, this is so influenced by the US and India. This is definitely, I don't want to speak for other settings because this is definitely those two experiences. Also experiences that are changing. Because I think even with the second wave, there was pushback even around about physicians here doing telemedicine consults with patients in India. They were worried about some strict licensing rules that have come up in the last year. So I
Well,
should
I
have.
can't do telemedicine with someone outside of BC. Right?
Yeah.
I'm not licensed in Alberta. I am actually licensed in Ontario, but because I have but I am not licensed in Alberta.
Yeah.
So I actually can't.
It's which is so interesting because there's a group of people in during the second wave. There was a lot of discussions, and there was a group saying this is an emergency. We can't abide by those laws. And then you think for a second, you're like, we're wading into some very dangerous territory if we start kind of pushing laws to the side. But I think it's with the intent was good, that it's just your intentions can sometimes have negative consequences. So
And I wouldn't undermine in all of this. I wouldn't forget, we always say, if you don't understand something, follow the money. Like, there is a lot of money in training non-Indian trainees in India. So there's US and NHS HMOs need people to work, right? And so it's a whole lot cheaper to let people train in India and then have them work, which I think is unconscionable. But so again, like, underlying all of this is, in many ways, if you're using India, high-income countries are allowing low and middle-income countries to pay the full freight of training people and have them practice here.
yeah, it brings up a whole question about migration and mobility, and oh my gosh, yeah.
There was one question on Zoom.
Okay.
We're texting here. Someone had their hand raised on Zoom.
Yeah, there are questions in the chat now. I'll read it out, but Mohammed, if you have anything further, jump in. There's a comment that in most settings, policy change when people in power change. So how do we move towards sustainable policies that don't disappear when
Oh, this is such a good question.
Can you read it out again?
Oh, sorry. Let me just pull this off a little bit. Okay.
Sorry,
In most settings, policies change. Let me try to see.
Veena is going to read it out again.
In most settings, policies change when people in power change. How do we move towards sustainable policies that don't disappear when a minister is removed? Happens everywhere, but very often in several LMICs in my experience. So Mohammed, that's absolutely true. Very, very true in India, I can say from experience. And it's a longer conversation. I think ultimately the weakness is personalized leadership, I think. There's always this tension between structure and agency. And one of the challenges is that we have leaned too heavily on agency in this context to say that a good leader can solve all problems. Well, it shouldn't only be up to a good leader. One of my respondents actually told me that she was a very senior government bureaucrat, and her sister had major problems. She was trying to push for palliative medicine because her sister had really struggled with it. And she was just thinking, she was like, I'm a person in a very high level of authority. I'm able to access these people. It should not be, and took 10 years for her to do it. And she's saying it should not be like this, that it's just dependent on who you are and who the bureaucrat is. There's got to be there has to be more modes of communication that are there despite who's in power. And I think that's probably a longer conversation. I have ideas on.
I think we could talk for a very long time, but I'm just acknowledging that it's 5 after and there's a class coming in at 1:15. So I just wanted to say one quick thing first. There is I have a little bit of food for those that are in person and want to run and grab it. I'll go get it as we're just wrapping up. And mostly, I want to say thank you so much. That was really excellent and amazing and engaging, and it brought so many more questions. And I will personally be calling on you for some things. And I just want to maybe a round of applause if you don't mind, because I really.